Hi, everybody. My name is Adam Pick, and I'd like to welcome you to the webinar titled Advantages of Mitral Valve Repair. If I have yet to meet you, I am a former patient, and I'm also the founder of HeartValveSurgery.com. Our mission is simple. We want to educate and empower patients with heart valve disease. This webinar, which had over 290 registrations from patients in countries all over the world, is designed to support that mission. During the webinar, all participants will be in what we call listen-only mode. That being said, you may submit questions during the webinar. Simply post your questions in the control panel on the right side of your screen. We will do our best to address your questions during the Q&A section at the back of the webinar. Lastly, as we conclude today, we're going to ask you to complete a very quick 5-question survey. Now, I am thrilled to introduce the featured speakers for this session. Dr. McCarthy is the Executive Director of the Bloom Cardiovascular Institute and the Chief of Cardiac Surgery at Northwestern Medicine in Chicago. Dr. McCarthy has achieved national and international recognition in the fields of complex adult cardiac surgery, including valve repair and replacement and atrial fibrillation. He has performed 10,000 heart operations, of which more than 4,000 involved valve therapy. You should also know that Dr. McCarthy is the #1 recommended surgeon at HeartValveSurgery.com. And as you can see here, he's had over 111 patient testimonials. It's truly incredible. And Dr. James Thomas is the director of the Center for Heart Valve Disease at Bloom Cardiovascular Institute. Dr. Thomas is an expert in cardiovascular imaging and is a past president of the American Society of Echocardiography. Dr. Thomas also serves, and this is pretty neat, as a lead scientist for ultrasound with NASA, researching the impact of space travel on the heart. I could go on and on about the careers of Dr. McCarthy and Dr. Thomas and their achievements in cardiac care. Instead, I will just tell you that this team is celebrated by the HeartValveSurgery.com community, and for very good reason. Since launching this website, Northwestern has successfully treated well over 100 patients from our community, including many of the folks you see here: Robert Winter, Sarah Bloomfield, Ron Rovin, Gene Cook, Sharon Knickerbocker, Lisa Woods, Mark Croto, John DeFazio, Carol Rice, Charlotte Hartzell, and Debbie Cross. And as you may have just seen, a few days ago, Dr. McCarthy and his team performed another successful mitral valve repair on Diane from Chicago. Personally, I'm humbled that Dr. McCarthy and Dr. Thomas are taking time away from their very busy practices in Northwestern to share their experiences in clinical research during this educational webinar. So to start, I'd like to introduce you to Dr. Patrick McCarthy.
Hey, Adam. Thanks for the nice introduction, and welcome to all the participants to this. And first, Adam, I want to thank you again for all that you do for the patients and their families, because people always come to us with a lot of questions and the anxieties, and whenever they go to your website, I think they feel a lot better. So it's really doing a great thing for the patients that need heart valve surgery. Before we started in this, we thought that Jim and I talked about just kind of introducing a patient that we had seen not too long ago to set the stage for what we're going to talk about. It's a 48-year-old man. We won't use his name, but he's been to your website. Mitral regurgitation for many years. He'd had echo follow-up. He was starting to develop an enlarged heart, even though he felt well. And so he was recommended to have surgery. And locally, where he came from, they told him the valve was in such bad shape that he was going to need to have the valve replaced. We see that a fair amount of time. But he came to us. I think he had searched us on your website. And in December, we did mitral valve repair, and he went home 3 days later. And Jane followed up with him recently, and he's doing great. He's exercising, and he's feeling fine. So that's just kind of the set the stage for the type of patients we're going to talk about. And now I'm going to introduce Jim Thomas. Jim is an old colleague of mine when the two of us were together at the Cleveland Clinic. And if you move on, Adam, he's going to talk about sort of the background, the cardiologist part about the heart repair. Yeah. First of all, hi everyone, and thanks Adam for putting this all together. I didn't really know you that well before I came to Northwestern almost 4 years ago, but I've really been pleased with our interactions, and I do support your educational and reassuring cause that you bring to the heart valve surgery world here. Now, I'm sure most of our audience understands that there are 4 valves inside the heart. Function of any valve is to make sure the blood goes in one direction. It should go forward through the heart, so it needs to present no significant blockage to forward flow, but present complete blockage to reverse flow, so the blood doesn't flow backwards there. And they're really quite remarkable valves when you look at them. They're sort of flimsy little things that you sort of are surprised they ever really work, but they do work remarkably throughout our life. Next slide. Now, as we mentioned, there are 4 valves. 3 of them are the most common ones to be diseased. The aortic valve frequently becomes stenotic or blocked. The tricuspid valve on the right side of the heart often becomes leaky, particularly in the presence of problems on the left side of the heart. And then our topic for today is the mitral valve, which lies between the left atrium and the left ventricle and promotes blood going forward into the left ventricle and prevent it going backwards into the left atrium. Next. Now, if you just do the math, it works out that in an average year, and this is not at a particularly high heart rate, heart valves open and close over 40 million times. And so carrying that forward to the next slide, add that up by age 65, they will have opened and closed over 2.6 billion times. And you can imagine by the time you get to 100, you may well have 4 or 5 billion cycles on all 4 of your heart valves, and yet for most of us, they function quite well throughout our lives. Next slide. There's a tremendous burden, though, of heart valve disease, and our topic today, mitral valve disease. There are about 5 million Americans with moderate or severe mitral regurgitation. And there's about a 10% risk once you get to be 75 years of age that you will have significant mitral regurgitation. Now, if you look worldwide, there's many more patients who have rheumatic valve disease, and that typically produces blockage, so blood doesn't go forward normally. But our topic for the most part today will be mitral regurgitation. Next slide. And in this diagram here, you can see that the label mitral regurgitation lies over the left ventricle, and when the left ventricle pumps, all that blood is supposed to go out the aortic valve, and none of it's supposed to go back into the left atrium there. But when the valve starts leaking, you can get a significant amount of the pumping function of the left ventricle actually pumping the blood backwards into the left atrium. This increased blood going into the left atrium causes it to enlarge, raises the pressure inside of it, and also backs up blood into the lungs, so you get congestion in the lungs with increased pressure there as well. Next slide. So what are the consequences of mitral regurgitation? Well, there are many things that we worry about. Of course, you may have symptoms of shortness of breath or things like that, but there are long-term consequences that even if you don't have symptoms, we are very concerned about. One of these is weakening of the left ventricular muscle causing heart failure. Remember, each beat, the heart may be working twice as hard as it ought to because it's pumping so much blood back and forth into the left atrium there. As I mentioned, we can get an elevated blood pressure inside the lungs,
and that leads to a condition called pulmonary hypertension, and that can eventually lead to failure of your right ventricle, and that's a very challenging thing to treat. Another consequence of the pulmonary hypertension is tricuspid valve regurgitation, and that's simply a matter of this back pressure causing the right ventricle to stretch open and the tricuspid valve to begin leaking itself. And then one of the most common complications of significant mitral regurgitation is atrial fibrillation, which raises the risk of strokes from blood clots that form in the left atrium, and also can produce real symptoms of just ill-being to many patients. Next slide. Now, when you see a cardiologist and you have mitral regurgitation, that cardiologist is going to do a few things. Of course, he's going to take a complete history on you and understand what your symptoms are. He's also going to do a physical exam, and quite often with mitral regurgitation, there will be a loud murmur with typical features. And as cardiologists, we learn how to recognize the different types of murmurs. He or she may also hear congestion in your lungs and find edema in your feet. There are a number of blood tests that can be ordered. Of course, there are some blood tests. There's electrocardiogram and chest X-ray, although to be honest, at least early on in mitral regurgitation, those have a fairly limited role. The most valuable test we have in our armamentarium is echocardiography, where we use ultrasound to bounce sound waves off the structures of the heart and build it up into a picture of the heart. Next slide. Now, about 40 years ago, a renowned surgeon in France named Alain Carpentier, who's really the father of mitral valve repair that Pat is going to be speaking about shortly, came up with a schema for describing why mitral valves leak. And we'll be talking today mainly about primary or organic mitral regurgitation. That means where the actual problem is in the valve itself. Type 1 is where the valve moves pretty normally, but it may have a hole in it. It may have gotten infected and have a hole or something like that in it. Type 2 is excessive leaflet motion, and that's the most common condition we'll be talking about today, where the valve really is prolapsing backwards or may even be ruptured and flailing back into the left atrium. And then there are two types of secondary or functional mitral regurgitation. The one that's most common is that once you've had a heart attack or have any sort of dilation of your left ventricle, it can actually tug on the strings that hold the mitral valve in place. And it will restrict the ability of the valve to close. The valve itself may actually be normal, but it's being pulled open by the abnormalities in the ventricle. Next slide. So we have ways of grading the precise amount of leakage that's going through the valve. And we typically grade this on a 4-point scale or descriptive scale, 1+ to 4+, mild, moderate, moderate to severe, or severe. But very important that we have very careful quantitation to help place it in the appropriate category. Next slide. So now this is an image, as you can see on the left. This is a classic sort of disease of the mitral valve. Remember that in organic mitral regurgitation, it's the valve that makes the ventricle sick. And you can see that structure on the left there. That is the posterior mitral leaflet that's going back into the left atrium, and that's allowing severe mitral regurgitation to pass into the left atrium. Adam, is it possible to play the right-hand panel or not on this? Yep, there we go. We use this color to show which direction the blood is moving. And we can tell by looking at the colors whether the blood is going forward or backwards. We're going to try it one more time. There you can see it's almost so leaky that you can't even really see the jet here, but trust me, that is a severely leaky valve. It would have a hole, effective hole through that valve of about a square centimeter, which is about as big around as a felt tip marker. Next slide. And now this is the other type of regurgitation that we call functional. This patient has had a large heart attack affecting the posterior wall of his heart, and the valve that's on the left as you're looking at the screen is the posterior leaflet, and notice how it's being tethered outward. It's sort of pointing up toward the top of the screen. That allows the valve to the right to miss it completely when it tries to swing shut, and that allows a very large jet of regurgitation to come into the left atrium. Again, that is basically a normal mitral valve, but it's being tethered outward by that large heart attack that this patient has had. Next slide. Now, we have a lot of data to guide the treatment of organic mitral regurgitation. Next slide. We know that leakier valves do worse. And so when we're trying to classify the severity of the regurgitation, we look at a number called the ERO, the effective regurgitant orifice area. And if it is greater than 40 square millimeters, we know that those patients will do worse over time. And when we see that, we start to think very hard about whether surgery is the right thing to do. Next slide.
And Dr. Thomas, it's Adam. Real quick, when you say the patients will do worse, what specifically do you mean from the patient perspective? Does that mean they'll experience more symptoms, there'll be more fatigue, or it will lead to other forms of cardiac problems for the patient down the road? Can you explain a little bit more about that?
Sure, Adam. Well, on this particular graph there, the word on the left is survival. So that means how many people will be alive after that period of years, and patients who have these leaky valves do worse. Now, this is sort of a natural history study here, so we very much want to interrupt that curve there, and if you operate on these patients, they will do much better. So we pay a lot of attention when we see that ERO getting over 40 square millimeters. But yes, they will typically develop symptoms, and they will develop other types of heart disease like atrial fibrillation. So yes, that's what we call severe. That is, in fact, the boundary line between moderate to severe and severe. And once we reach that truly severe stage, we start to have some very serious conversations with our patients. Next slide. We also pay very close attention to the pumping function of the left ventricle here. And these are patients, they all have severe mitral regurgitation, but we have stratified them by the severity, by the percentage of blood that is pumped out of the ventricle on each pumping cycle. And you can see that if you pump over 60% of your blood out each cycle, you do better over time than those who have a pumping fraction less than 50%. Now, understand that in most situations, an ejection fraction of 50% is still in the normal or low normal range. But in the setting of mitral regurgitation that's severe, that is a real red flag that we need to move quickly, because ventricles do not do well at this level when they have severe mitral regurgitation. Next slide. There, I think, yeah, we call those decompensated. Anything under 60% we call decompensated, even though that is really a normal ejection fraction in other settings. Next slide. So now we've made the diagnosis, and we've decided that something needs to be done. So I'm going to hand it over to my surgical friend, and he will describe the appropriate use of cold hard steel here.
Thanks, Jim. So what we're going to look at is a sort of a series of pictures from the surgeon standpoint. I tell my patients when I meet them, the black and white shadows and then the flashes of color like a bunch of flowers are really helpful. But, you know, I get into real looking right at the valve when we do this. This is truly open heart surgery. We literally open the left atrium. Adam, can we move to the next one? So the question was, what are the advantages to mitral valve repair? That was the title of it. Well, some valves can be repaired and some can't. The one that we're mostly going to talk about is one that Dr. Thomas had referred to as type 2 or degenerative. People hear different words about it. Mitral prolapse. People commonly say they've been told they have prolapse since they were in their 20s or something. We also call it degenerative valve disease or Barlow's valve, sometimes you hear about, or myxomatous valve, or fibroelastic deficiency. But basically what it means is that there's some strings on the valve and that they are not doing well. Since your heart beats 20 million times every year, that is in fact a lot of wear and tear, and sometimes the strings on the valve don't hold up. Next slide. So how do we repair it? You can move on now to the next one then too, Adam. So this is kind of a typical picture for what one of those valves may look like with degenerative disease or myxomatous disease. And so here at Northwestern, we actually measure a lot of things about them, and we have a database with thousands of these. So there's two leaflets. There's the anterior leaflet, that's A2 I marked up there, and then there's the posterior leaflet. So mitral valves have two leaflets. And then there's, you may see in some of your echo reports, P1, P2, P3. The most common condition that we face is broken strings, or what we call a flail, of P2, the middle part of the posterior leaflet. And that's also kind of elongated. That should only be about 10 millimeters, which is about half an inch. So it's almost an inch tall. It's way too tall. And then the strings broke on it. Next slide. So how do we fix that? So the most straightforward one that I'm going to show you, and this probably applies to about 70% of the patients that we do, is that we cut out the areas where the strings broke. And I tell patients when I see them, many of you I bet have heard this conversation before, that your valve is like a parachute and there's strings on the parachute. And it's as if one corner of the parachute, the strings have broken. And so you could picture a parachute with both broken strings, and it's going to leak a lot there. So the way we repair that is we cut out the area where the strings have broken. And then I use very fine sutures. Those are about the width of a human hair. And then we put the valve back together. And what I'm showing, this is more for the surgeons, is precisely how we do that. And we want to get the measurements just right. We want to get the posterior leaflet half the height of the anterior leaflet. And so this is for my surgical colleagues, and we talk about how we put this back together. And then we cut out the broken part and we sew it back together and make it the proper height. Can we go to the next slide then? So after we have it to the proper height on the left side, what you'll see is that there's also little what we call clefts in the valve, which is how you separate, how I can identify P1 from P2 and P2 from P3. And so we put usually a couple of additional sutures there. And then the final thing is that the valve has been pulled apart. It's not just that the cords broke, but in addition, the valve itself is stretched. And so we have to put a ring around it so that it comes back into a proper amount of overlap. And so the rings come in different shapes and sizes. So some are kind of small and some would be extra large. And so we have to choose the right ring to fit that specific patient. And we don't know until we're there. It depends on what the measurements are and how we've repaired the valve, what we would do. Next slide. There's different ways to do it. What I showed you is sort of the time-honored tradition of resecting the area with the broken strings. Dr. David up in Toronto had pioneered this other technique that is also very popular, which is to add artificial cords. So think of the parachute being repaired with some new strings on it. And so what they use is like little sutures of Gore-Tex, and they tie it down to the muscles of the heart where the strings originate, and then they have to get the length just right so that they can do that. So that's another technique that the surgeons have in their repertoire. Next slide. And then another one is sometimes you'll hear about an alveoli repair, we call it, or an edge-to-edge approximation. And we do that sometimes when the valves are really getting complex and there's multiple areas where the cords are too long or broken. And we can actually sew little bits of the valve together. For instance, in this one, it's right in the middle of the posterior and the anterior leaflet, and that's called the alveoli repair. And that way you have normal cords that are supporting the abnormal area. And you turn the valve into, some people call it like a bow tie look on the left, where you have two smaller orifices there. Next slide. So that was a procedure that began back in the 90s, and then interestingly, as a little sidebar, Mehmet Oz was visiting me at the Cleveland Clinic. Mehmet is a heart surgeon, and I was doing that, and they started working on a patent that eventually led to this. It's called MitraClip. And so a new way that is non-invasive is to be able to go in there and instead of suturing the two leaflets together, you clip them together with a little metal clip. And so we'll talk a little bit later probably about MitraClip. It's a good option for patients who are, for instance, elderly and have a lot of other medical problems, maybe need a second or third operation. So for the right patient, it can be good, but that's actually more the exception rather than the rule. Next slide. So what are the advantages to the repair? First of all, it's resistant to infection, and it's resistant to stroke. Your body covers the white part of that ring that is there, and so it gets incorporated, and so patients are far less likely to get an infection than they are with a replacement valve. And also, since it's just natural tissue, the patients don't have to be on blood thinners typically, so they don't take Coumadin or anything like that. Next slide. So what are the disadvantages? I showed you a real simple one where it was just the one area where the strings are broken, but it can be complicated, and maybe you could determine looking at that echo for the black and white shadows that we don't always know until we get there just how complicated it's going to be. So even though many of the patients, I tell them that chances for repair are over 95% or, approaches 100%, nothing in medicine is 100%, and we don't know until we actually look at the valve. It's also something where there aren't a lot of people that do this. It tends that there's a handful of us who do a lot of them. For instance, I do about 200 a year, but across the country, most of the surgeons do 5 to 10 a year, and so it takes a little bit of judgment. The other disadvantage is that later other cords or the strings on the valve might break, or you could have scar tissue that could form that might keep the valve from opening properly. But you can also get scar tissue that forms over a replacement, and like any operation, you would get scar tissue potentially forming. So we see that sometimes. I'll talk about it, but it's not very common, neither of those. Next slide. This is an example. So this was recently we looked at the group of patients that I just talked about with that degenerative mitral regurgitation, DMR. It's about 900 patients that I did, and Jane and her group were doing the follow-up on them, and 10 years later, 99.6% were free of needing a second operation. The group that it tends to be in the first year. So in the first year in particular, might be when people form scar tissue, or it might be if somebody breaks a different cord. And then every once in a while, there's something rare that might happen, like an infection. But for the most part, when we fix these valves today in the current climate, then they're going to have a really long durability of decades, hopefully for the rest of their life, is what we expect for most patients. This is much better than the data that was done in the 1990s when we were really just kind of pioneering this, like when I was at the Cleveland Clinic. So the results today are a lot better than they used to be. Next slide. So sometimes, though, as I mentioned, you can't repair the valve. It may be, for instance, Dr. Thomas had mentioned there's 20 million people with rheumatic fever, as an example. Rheumatic fever causes a lot of scar tissue. The scar turns to calcium, and then you can't reliably repair those valves, and so you have to replace them. So broadly, there's two kinds, mechanical valves and tissue valves. There's pig valves and cow valves. Here at Northwestern, we almost always use cow valves. Next slide. So of those two, why would you choose a mechanical valve? Well, the advantage to a mechanical valve is that it sort of lasts forever. The valve itself works. Those mechanical parts are made out of carbon and all. They don't break. They don't always quite last forever. For instance, today we're taking a patient in transfer 12 years out, and she formed scar tissue that is over the mechanical valve and is keeping it from opening. So theoretically, the mechanical valve would last forever and patients don't need another operation, but in reality, sometimes they do. The big disadvantage day to day is that you run a risk for a stroke, and it can be pretty high, and so it would be 2 to 3%. Sometimes patients come to me and they think it's just 2 to 3% total that is per year. So for instance, at 10 years, it's 20 to 30% risk for a stroke. 20 years, it goes up to 40 to 60, depending on the age of the patient. And therefore, you have to be on Coumadin, which is a blood thinner, not a very friendly drug, and at a high dose of that blood thinner, which interacts with all sorts of other things. And you would certainly not want to be on a blood thinner on the half pipe in the Olympics and bang your head on something in a blood thinner. So that's a drug that people have to be very careful about. And finally, some people say the noise bothers them. It's very unpredictable. We can't tell when it is or is not going to bother them. But in some people, once they have it, it kind of drives them crazy. Next slide. So tissue valves, why do that? And the majority of valves these days being replaced are tissue valves. The good thing about those, and this would be on the right, would be one of those banged up, scarred valves with a lot of calcium. In that group of patients, most patients don't need to be on Coumadin. They are with any mitral operation for about 3 months at a low dose, but long term, they typically just take aspirin. It's not living tissue, cow or pig tissue. It's been treated, so you don't really reject it. The disadvantage is that they wear out. It typically is dependent on the age of the patient and a few other things like kidney failure that may impact it. But for instance, a tissue valve in an 80-year-old could easily last 30 years. That'll probably last them. But if it's in a 20 or 30-year-old, then it may only last 10 years. And so it depends a lot on the age of the patient. Next slide. And here's an example of a patient. For instance, this was a 91-year-old patient who had had a pig valve, and they occasionally will pull away from the frame around there, and they'll tear. And so that 91-year-old, this many years ago, needed a second operation. Fortunately, she did well. Next slide. But we think that the days of doing second operations are starting to come to a close. The nice thing also about tissue valves is that you can put a heart valve inside it. 10 years ago, this was highly experimental, almost science fiction, and now it's FDA approved. So what we can do is go up through a vein in the leg, up into the heart, cross the septum, it's called, in the upper chambers, the atria, turn the new valve around and put it inside the old cow valve, and then blow up a balloon, and it just sits there inside the old cow valve. And so most of the patients today that are getting a tissue valve, if it does wear out in 15, 20, 30 years, that may well be what happens, is that they won't go through a second operation like what I showed in the 91-year-old patient. They'll just come in and spend a day or two in the hospital and get it treated this way. that was basically it, Adam. We tried to give you a kind of high-level overview of mitral repair, but then also sometimes what do we do when we can't repair the valve.
Yeah, and Dr. McCarthy and Dr. Thomas, thank you so much for sharing all of that incredible information specific to the repair advantages and tissue valves as well. We have, as you have been talking, questions have been literally pouring in from Lincoln and Don and Michelle and Don again and William. And so we're going to shift gears and go into real-time Q&A here. And one of the questions is coming in from Alice. And she says, if you have been diagnosed with myxomatous degeneration of the mitral valve and it has repaired, approximately how long will that repair last?
Yeah, so Alice, that was that curve that I showed, and it depends on the level of complexity of the valve. But these days, if it was being repaired, then most patients it's going to last the rest of their life. If it was repaired back in the 90s and it was very complex, and it involved both leaflets and all, especially the anterior leaflet, then the results may not have been as good. But even in that group, 20 years later, about 90% are still working. And so we sometimes see people with a failed repair late, but it's not that common. Usually they last.
Okay, and moving on again, everybody can continue to post their questions in the control panel on the right side of your screen. And to your point, Dr. McCarthy, Sarah just asked, is mitral valve re-repair common? Is this a subspecialty or do all cardiac surgeons do this? I will be needing this in the future. My old repair held for 15 years.
So mitral valve re-repair when it's necessary, which is not all that common, when it's necessary, sometimes you can repair it and sometimes you can't. It's hard to predict. Dr. Thomas and I just reviewed a patient earlier today that's about 15 years out, and he will need a second operation. It's definitely a subspecialty, and it's almost a subspecialty. Even of the repair surgeons, the ones that do 20 or 30 a year, these don't come along all the time. It depends on the age of the patient, too. If a patient is 75 years old, and I think that a tissue valve is going to last them the rest of their life, then I would tend to do a replacement rather than run the risk of a repair not working.
Yeah,
got it.
That's right.
Sorry, go.
Just to say that we often ruminate over these very hard to decide, is it something that's likely to be repairable again, or is it the better part of valor just to go ahead and do the replacement?
Got it. And Tammy asks, and we've touched on this throughout the session, is a question about Afib and mitral valve. And she asks, when my mitral valve gets fixed, will that help my Afib?
So it sounds like she hasn't gone through surgery yet. So if she is getting atrial fib and it is related to the mitral valve disease, or even if not, then typically we treat the atrial fib. It's called the Mays procedure, and Adam has some information about it on the website. So it's now called a class 1 indication, meaning that if you're there to fix the mitral valve, then the surgeons should do it unless they have a really good reason that they don't think that they should. So treating the mitral valve in itself, if you have atrial fib, will help a little bit, but you should do this ablation that's called the Mays procedure that will really help a lot. And then the chances of having recurrent atrial fib will be much lower after that.
Yeah, and to this point, Dr. McCarthy and Dr. Thomas, I have read that oftentimes when a valve procedure is being done and the patient has AFib, at times the AFib can almost be left behind and not treated by clinicians. Is that somewhat accurate or completely false?
So it commonly is done that way, but it's getting more and more common. So 10, 15 years ago, they came up with some new technology so that we can do ablation pretty quick and easy. Right now, we use what's called cryoablation so that we can ablate the areas where the AFib comes from. It adds about 5 to 10 minutes to the mitral valve operation to do that. I think across the U.S., the last we saw, it was 60% of the time when people had atrial fib before mitral surgery, it was being treated. but it varies. So for instance, here at Northwestern, it's 97%. So somebody has atrial fib before surgery, and I know it can cause a stroke or it can cause other things. We just go right ahead and we treat it unless there's a particularly good reason not to. But that is not the same everywhere.
Got it. All right, let's keep going with the great questions here. Paul asks, I was diagnosed 10 years ago with mitral valve prolapse. It just recently progressed to moderate. The doctor said we're going to wait and see what happens. Will I need mitral valve repair?
Well, that's a great question, Paul. I think the first question you need to understand is have you really had an accurate quantitation on the valve there? And you know, we try to educate the cardiology community and the echo community so that these studies are done in a uniform manner, but you do need to make sure that you are really going to a center that sees a lot of heart valve disease and is experienced at quantifying the degree of regurgitation, because I see a lot of valves that are read as moderate, and some of them are mild and really are not going to cause any problems. Some of them are severe and should be addressed more aggressively. The notion of wait and see, though, is a very well-established approach to this, and I've had patients that I've followed for 15 years before they finally progressed to the point that they needed to be done. You need to be seen regularly, depending on the severity. You may be seen every couple of years, every year, every 6 months. And one of the tests that we like to do is to put patients on the treadmill and see just how far they can go, and then look at their mitral valve with the echo after they've exercised to see if it is getting worse under those conditions. And that will help guide us when the time comes to operate on them. I think as long as you're being followed very closely, this is a perfectly acceptable way to be managed.
Great. And let's keep going. Jerry has a request here. He writes, looking for some information about the Neocord procedure.
Sure. So Neocord is a new approach to treating patients with mitral valve prolapse. There's also the Harpoon. Those are two different companies that are out there to treat it with kind of similar approaches. I mentioned that, like the strings on the parachute, one approach was to essentially add new strings, which would be the artificial cords that I showed, mentioning it from Toronto. So this is a new experimental procedure with Neocord, very small incision at the tip of the heart on the left side of the chest. The surgeons go in through the very tip of the heart and then essentially kind of spear or harpoon the leaflet where the strings broke, and then attach the new strings and then pull them down and secure them to the surface of the heart. It's been mostly in Europe right now, several hundred patients in Europe, and it's just barely beginning in the U.S. And, you know, for such an early experience, it looks, I would say, kind of encouraging. It's not for everybody, especially if you have a really complicated problem with multiple cords and many different areas. But it's one that we're following closely, and we'll be joining those studies with Harpoon as soon as those begin.
All right. And here is a procedural question about the process of open heart surgery. And Dr. McCarthy and Dr. Thomas, a lot of our patients in our community are very nervous or anxious about waking up with the ventilator tube. And JP asks, please ask if it is possible to keep a patient under anesthesia until the tube is removed after open heart surgery.
Yeah, I don't blame them. That would be the part of it that I hate the most. That's what people certainly say that they don't like. So it's completely different than it was 20 years ago when I was beginning my career, and people had that breathing tube in typically overnight. Any of my patients may remember one of the very first things I ask them is, do they smoke? Because if people don't smoke, then that breathing tube comes out right away. And if people do smoke, of course, they should quit, but especially quit if they're going to go through heart surgery. So waking up after any heart operation like this isn't like when you wake up in the morning when your alarm goes off and a minute or two later you're wide awake. It's very kind of slow and staged, and so people kind of gradually come out of anesthesia these days. Most people here at Northwestern, the breathing tube comes out about 2 to 4 hours afterwards. The majority of them don't remember it. And the ones that do remember it, most of them don't remember it very well because they were still kind of groggy. But it's not like the old days. People used to just hate that thing for good reason.
Yeah. Yeah, and we've got a question here, Dr. Thomas, about going back to your discussion about symptoms, and it is it common for a patient who is completely asymptomatic to go through with a mitral valve surgery?
I wouldn't say it is common for that, but it certainly happens. And, you know, patients have remarkable abilities to accommodate for things that are going on. First of all, they may not appreciate, and we noticed, I don't think the question has flipped over yet, unless it looks like we may have signed out of our account here, Adam. But that is one of those situations where usually it's the symptoms that bring the patient to attention, and they would have that. But it happens not uncommonly that a patient may be relatively asymptomatic, and that's one of those situations where we like to put them on the treadmill, discover if they really are asymptomatic when they really go on the treadmill, and it lets us plot that over years. But if we see a situation where the pumping function of the heart is starting to deteriorate, or the pressure is going up inside the lungs, or a number of other things that we know are markers for bad outcomes, we will recommend surgery for those patients, even if they truly are completely asymptomatic, and they typically will do very well afterwards.
Hey, Adam, can I mention a bit about that too?
Sure.
Remember earlier we talked about 20 million heartbeats every year. So every time your heart beats, the blood goes back and forth, back and forth. And over those millions of heartbeats, your heart starts to get enlarged, and when it gets weaker. And so he had talked about that the heart can get weak. Dr. Thomas had mentioned that, and people eventually can develop heart failure. And remember, the patient that we used at the beginning of this was totally asymptomatic. So the patients these days that go through surgery, about 50% are supposedly asymptomatic. Now, having said that, when you ask them really carefully, they say they feel fine. I always tell people I look at, their spouse sitting over there, or whoever, their friends and family, because the patient always says they're totally fine, but they're shaking their head no. And they say, he gets tired, or, he gets a little winded going upstairs. We go for walks. He can't keep up like he did a year ago. So that asymptomatic is a little bit fuzzy sometimes.
Yeah. We also find a lot of times afterwards, you ask them how they feel. They say, I feel a lot better.
Yeah. They didn't know that they were kind of cut back.
Yeah, and so this is a question designed for both of you guys. It's a question that I always talk to patients about, and I'm curious to know your feeling is, what do you consider to be the most important two questions patients should ask their surgeons, their medical teams, when diagnosed with severe mitral valve disease?
Well, I'll start this out here, and I think there are different settings where people find out about this. But I would say for sure you want to end up with a very experienced medical center and an experienced surgeon who is doing a lot of mitral valve procedures, seeing a lot of patients with valve disease, and really know how to approach them. So if you're in a smaller community where they may do very good surgery for bypass grafts and things like that, it's appropriate to ask if you should be seen at a center that really specializes in heart valve disease, and there's a real heart team that works so closely together the way Pat and I do and our interventional colleagues. So that would be a question I would like patients to ask, and then I'll turn it over to Pat for his approach here.
So Adam, the approach we have is the same one that the patient would have, which is basically what are the risks and what are the benefits. And so for a healthy 55-year-old sort of typical patient, the risk to their life to go through this open heart operation is much less than 1%. And the other risks are also quite low. And then the benefits are, in particular, if the valve can be repaired, that hopefully it's going to stay repaired, and it reestablishes, puts them back on the curve to have a normal lifespan. And so those are risk benefits. Now, different scenarios, if the patient is 85, has had prior heart surgery, that risk is going to be a lot higher, and then the benefits may be lower, and then maybe we would be looking at MitraClip or something that's less invasive and kind of quick and easy. But kind of figuring out that equation of what's the benefit versus the risk is what we're always doing when we talk about these patients.
Well, great questions and great points. And with that response, we're going to go ahead and start winding down the webinar, but please don't leave just yet. On behalf of the entire HeartValveSurgery.com community and all the patients across the world with valve disease, I'd like to really extend an extraordinary thank you both to Dr. McCarthy, Dr. Thomas, the entire team at Northwestern for helping put together this webinar, for sharing their expertise with all of us today. As we end the webinar, I'd also like to thank you, all the incredible people from our communities, all the attendees, for your participation in this very special community event. And lastly, as we close out, I'd like to ask you to complete a very quick survey that is about to appear on your screen. And as we always say here at HeartValveSurgery.com, keep on ticking. Thanks so much, Dr. McCarthy. Thanks, Dr. Thomas.
Thanks, Adam.
Thanks a lot, Adam. Thanks, everyone.